Virendra Arya to speak on post-op analgesia for open thoracotomies and open cholecystectomies.
So I am going to talk about this, how to manage post-operative acute pain in open thoracotomies and open cholecystectomies. Now this topic is combined. So let us see what is special about these two surgeries. The one thing is that there is multimodal origin and transmission of the pain. It is severe pain, quite intense, which may last up to the weeks. It is aggravated by the respiration, so it affects our respiratory mechanics. And presence of chest tubes and drains, they further worsen the pain. And if this pain is treated insufficiently, what we can have is pulmonary problems because the patient is not able to cough, deeply inspire, hence developing atelectasis, pneumonia and respiratory failure. Prolonged immobility because of these problems can lead to the deep vein thrombosis and pulmonary embolism. And both these deep pains, if not treated well, they are associated with more conversion into chronic painful syndrome, and some studies showed up to 40% incidence of chronic pain syndrome, which means pain lasting more than 2 months. Now let us see like thoracotomy pain. It has multiple sensory afferent, like the incision site. It may be carried by the intercostal nerves. Chest drains, it will be carried by the lower intercostal nerves. Then central diaphragmatic irritation, those sensations will be carried by the phrenic nerve. Mediastinal pleura, if irritated, it is carried by the vagus nerve. And then ipsilateral shoulder pain can be carried by the brachial plexus. So that means the afferent fibers are multiple and they cannot be blocked by a single technique. Hence we have to attack on the multiple levels. We can have systemic opioids, we can have local anesthetics, and we may have to use the anti-inflammatory drugs. And based on that, we have multiple modalities to treat these pains, and let us see what combinations are going to suit to our patients. The choice of the techniques will depend the patient factors, what are the contraindications for a given patient, what are the preferences, what are the surgical factors, what is the length of incision, what is the site of incision, and what is the system factors in which you are working, what is the sport, what is the equipment, and what is the expertise. In these surgeries, the plan for the pain relief should always be decided beforehand. Now, among systemic analgesia, we have the opioids. Now, they are effective in controlling the background pain. However, the acute pain associated with coughing and deep inspiration is not well controlled by them. And if we try to control that, the patient invariably gets sedated and there are more side effects. Even the PCA devices, this pain related to the chest physiotherapy, deep inspiration is not controlled well, and interrupted sleep pattern will be seen whenever the plasma concentration will go lower than the therapeutic threshold. This article shows that if you give the IV PCA opioids, they are comparable to the epidural morphine. However, the dose required in IV PCA is quite high. Like in morphine, first 24-hour requirement may go up to 50 to 100 milligram. In case of tramadol, up to 450 milligram, whereas in epidural space, just 5 milligram of morphine will do the same thing. Non-steroidal anti-inflammatory drugs, they are specifically good to treat the ipsilateral shoulder pain. However, they are not good for overall treatment of these pains. They do decrease the opioid consumption by 30%. However, they are having their own side effects. Nowadays, low-dose ketamine, that has been used for the pain relief, and specifically it is good when the pain is refractory or the common modalities are contraindicated. The problem of psychomimic effect, they are there, but it is claimed that with sub-anesthetic analgesic doses, they are rarely seen. This study shows that when the ketamine was added to the PCA morphine, it definitely reduces the requirement of the morphine as well as improved the respiratory function, And in cholecystectomies also, open cholecystectomy also, this ketamine given in sub-anesthetic doses gave good pain relief to the patients. Dextromethorphan is the another drug which is being nowadays used for the pain relief. The advantage is that it is free of the renal effect and it does act in synergism with epidural drugs. However, it has the problem that it does cause some amount of hypotension and reduction in the heart rate. Nowadays, there was a review article and a meta-analysis of perioperative magnesium sulfate which was used in bolus and infusion, and it was found that it does reduce the perioperative consumption of the oral opiates. Local anesthetics. The commonest way can be you infiltrate the incision site, like for the cholecystectomy, and it used to be a common practice. However, one of the Australian studies showed that this local infiltration is not very good in open cholecystectomies, and rather it does not improve the respiratory function. But with a caution, the same author said that it might be because of the problem of the surgeon who is infiltrating and who was not infiltrating it good. Intercostal nerve blocks, they can be done percutaneously under direct vision, but the practical tip is that injection should be avoided into the intercostal vessels, and it should be placed close to the posterior axillary line so that the lateral cutaneous nerve is not escaped, and dose should be restricted so that the toxic levels should not be achieved. Nowadays, the people are inserting catheters also for continuous intercostal blocks, and it has been shown that when the drug is given as a continuous form for the intercostal blocks, actually it acts same as a paravertebral block. In this study, they showed that the continuous drug given through these catheter actually went into the paravertebral space. Now, thoracic epidurals and intercostal nerve blocks were compared, and good results were achieved, but intercostal nerve blocks has to be supplemented with some other form of analgesia like PCA or spinal morphine. But if you give the intercostal nerve blocks in addition to epidural, then there is no significant benefit in the pain relief. In a prospective study, when the intercostal nerve block, but now the surgeons were coming into it, they were saying that if we can prevent the entrapment of the intercostal nerves when they are closing the thoracotomy wounds, then perhaps the pain can be relieved. So they devised different types of the chest closer, thoracic wound closers, and they said that if they can dissect the nerves and then close it with covering with the flap, then perhaps the entrapment is less and the pain related to the thoracotomy can be reduced. However, in the study, it was found that the chest closure and protection of these nerve technique did not affect the post-operative pain. Intrapleural analgesia was tried. However, it is highly unreliable and it depends upon so many things. Hence, nowadays its routine use is not justified. And in one study where it was tried to relieve the shoulder tip pain, it was found that it is not effective. Thoracic epidural anesthesia, yes, it is very important. It decreases the incidence of respiratory complications, and with newer devices of the continuous infusion pump, which are small and portable, mobility of the patient can be established early. And combination of local with opioids definitely is a big boom, and the complications with thoracic epidurals are less. The success rate can be more with paramedian approach, and the dural puncture incidence is also reported less than the lumbar epidurals. The questions are whether it should be given in thoracic or lumbar regions, whether combination should be used, and which type of opioids should be used. So, in this study, where basically thoracic and lumbar epidural were compared for the thoracotomy pain, they found that when the thoracic epidural is given, the side effects like hypotension and the other pruritus, those were less with the thoracic epidural in comparison to the lumbar epidurals, because in lumbar epidurals you need to give more drug to achieve the higher levels. Similarly, when you use both the drugs, local anesthetics and opioids, they have the synergism, and it has been found that the CSF level of each drug is higher when you use in combination rather than alone. So that means they increase the penetrability of each drug also into the CSF. Thoracic epidural bupivacaine also attenuates the supraventricular arrhythmias, which is usually associated with the pneumonectomies. Hence, if a combination of local anesthetic and opioids is used, that has the additional effect in protection against the supraventricular tachyarrhythmias. Which opioids? It depends which class of opioids you are going to use. The more hydrophilic opioids, they have wide-band analgesia, they can have rostral spread, but incidence of pruritus, nausea is also high. There is delayed onset, approximately up to 3 to 4 hours, and they are high potency when given in the epidural rather than in the systemic route. Whereas the highly potent, highly lipophilic drugs, they have more narrow band of the analgesia. Their systemic effects are less, but they tend to develop tachyphylaxis, and they have relatively low potency or comparable potency with IV as well as the epidural injections. Now coming to the paravertebral blocks, the paravertebral space is basically potential space deep to the endothoracic fascia, and it can be approached by the percutaneous approach. It can be given by basically the ultrasound, and even during surgery the surgeon can place the epidural catheter into the paravertebral space. But the important point here is that they have to seal the entry point with a stitch, otherwise the block is ineffective. The problem with this is because this space is close vicinity to the pleura, the absorption of the drug is quite high, and it has been seen that even the bupivacaine used in 0.5%, 0.1 ml per kg per hour, the serum levels tend to reach toxic levels by the end of 4 days. So it cannot be used in the same rate more than 3 to 4 days. There is definitely decreased respiratory morbidity in high risk. It is not demonstrated that paravertebral block is really effective when the respiratory complications or the respiratory morbidity already is existing. Now, this is a meta-analysis where the paravertebral block was compared with the epidural, but this study in paravertebral block was combined with some additional, like here it was combined with the spinal morphine, and they found that the effects are good, and the complication rates which are or the side effect which are related to the epidural, they are less with the paravertebral block. There is less chances of the urinary tension, there is less chances of the hypotension with the paravertebral block. And recently they have again proven that the VAS scores, they are statistically same in the epidural and paravertebral block group, and it can be a good alternative where basically epidural block is contraindicated because of certain reasons. So in this editorial they concluded that epidurals are definitely useful for the pain relief after the thoracotomy. However, this paravertebral block remains a reasonable alternative for the thoracic epidural. Cryoanalgesia, it was practiced, but because of the increased incidence of the post-syndrome, post-neurological syndrome with this, nowadays it is not much practiced. TENS, it is as good as placebo for thoracotomy as well as for the cholecystectomy. Now, when we are managing these patients, there are certain issues. Shoulder tip pain, the incidence is quite high, and when we are facing this problem, we must rule out the other causes, like whether the chest tube is placed too much high. If the incision is extending too much posteriorly, then the epidural block does not block the area nicely, that can be the reason. If the patient is having the chronic osteoarthritis of the shoulder joint, then the positioning of the shoulder can itself aggravate basically the shoulder tip point. So these things should be kept into the consideration, that what is the cause of shoulder tip pain after these surgeries. Now, low volume interscalene plexus block was found effective for post-thoracotomy shoulder tip pain, and if during surgery the central diaphragm is infiltrated, that is also found more effective than the suprascapular nerve block. Recently they found that if there is a local tenderness over the shoulder, then the supraclavicular nerve block is more effective for this shoulder tip pain. The other issue is in post-cholecystectomy syndrome, if the pain is not getting relieved by the conventional methods, then you must rule out the surgical causes for the exaggeration of this pain. Post-surgery neuralgia, the incidence can be nicely reduced to less than 15% if perioperative analgesia is given nicely. The end point is that in the resting phase, patient should not have any pain, and during chest physiotherapy, during coughing, deep inspiration, the VAS should not be more than 4. So to conclude, the analgesia plan should start preoperatively in a given patient. Most of the patient in our center, they use the epidural, but if there is any contraindication for the epidural, then you should think ahead that what alternative you are going to use for that patient. paravertebral block with spinal morphine can be a very good alternative. Multimodal approach is required because the efferents are multiple. Then the institutes which you are working, what is the support system, that is most important to think and to plan for your this thing. Another important issue is that in literature you might be finding many articles, many meta-analyses, but you must pay attention. Those multiple articles, those multiple meta-analyses which are repeatedly coming into the literature, but not becoming the standard way of practice, that type of modalities you should take with a pinch of salt. Thank you very much for your